Now we are moving to our next session, and is the management of CKD in primary care, a patient journey, and we will focus on lifestyle modifications and treatment. We are now with our patient David. 10 years later, he is now 57 years old. He has diabetes for 15 years, dyslipidemia, hypertension, background diabetic retinopathy. His blood pressure now is 140/82. His body mass index is 28 and the A1C is 8.2. His estimated GFR is 55. His urinary albumin creatinine ratio is 156 milligrams per grams. His total cholesterol is 209, LDL cholesterol 115 milligrams per deciliter, HDL cholesterol 42, and triglyceride 270 milligrams per deciliter. Current treatment of David is sitagliptin on metformin extended release 50/850 twice a day, ramipril 5 milligrams once a day, and atorvastatin 20 milligrams once a day. So let's put David now under stratification. So according to KDIGO classifications of the CKD, and according to the EGFR and UACR, David is now on CKD stage 3A. His GFR is 55, his UASR 156, and the star is on stage 3A. That means he is now on high risk, and we have to do something with his treatment. So our question now to the audience: which of the following treatments would be suitable at this point? A, stop sitagliptin metformin and A, the GLP-1 receptor agonist plus metformin. B, increase sitagliptin metformin to 50/1000 twice a day and add an SGLT2 inhibitor. C, continue sitagliptin metformin 50/850 twice a day and add an SGLT2 inhibitor. Or D, increase sitagliptin metformin to 50/1000 twice a day and add a mineralocorticoid receptor antagonist. So please vote. So I will pass on now to Sam in order to speak about lifestyle modifications and treatment. Professor Seidu, the stage is yours.
Thank you very much, Baruch. Certainly in the primary care setting, one of the things that we do very well is lifestyle modification with the assistance of our healthcare assistants and nurses. We do this part really well. So in a patient like this, you have to emphasize on their dietary habits. And so the dietary habits has to include protein restriction to about 0.8 grams per kilogram body weight. But of course, this patient is not on dialysis yet. If they were, you probably want to increase that to 1 to 1.2 grams per kilogram body weight. In addition to that, sodium restriction is also necessary. The WHO recommendation of less than 2 grams per day is to be emphasized in this case. Physical activity is important. Aiming to get your 150 moderate to vigorous physical activity a week is important. Evidence shows that increasing your physical activity levels can decrease your proteinuria. And then, of course, the same thing applies to smoking cessation. These patients have already had cardiovascular events. So smoking cessation is not just going to be helpful for reducing the cardiovascular risk, but also the proteinuria. Get the patient to stop smoking. And of course, weight management, getting the patient to lose weight would also help. When you have done all this, then we will now jump into pharmacotherapy. And from the KDIGO diabetes kidney disease recommendations, we now have very clear pathways of adding medications after your lifestyle. So in this patient, you could consider an SGLT2 inhibitor, given that the eGFR is more than 20, you can continue on to dialysis and even transplant in some cases. Metformin, the eGFR is still high, above 30, so you can safely continue to metformin. And the patient's metformin dose can actually be optimized because the A1C also needs reducing. RAS inhibition, the patient is on Ramipril, which is good. 5 milligram Ramipril can also be optimized. A lot of the time in primary care, we are quick to start ACE inhibitors and ARBs, but we don't optimize to the maximum tolerated doses. So these patients, ACE inhibitor could also be increased. And finally, given that the patient has had an event, and indeed, just by having chronic kidney disease alone, they are at a very high risk of the subsequent cardiovascular event. So you've got to optimize the cholesterol, lipid lowering therapies as well. And there are a lot of options available now in addition to your statins. PCSK9 inhibition, you can refer to your specialist to help with that. In other areas where you have bempedoic acid and icosapent ethyl, all of those are options that you can use to get your cholesterol down. If you have done all this, you now have to focus on whether this patient needs optimizing of their glycemic control, in which case a GLP-1 receptor agonist can be added. And also, if the proteinuria is so significant, despite your ACE inhibitors and ARBs and SGLT2, then your non-steroidal MRAs could also be added at this stage. So the KDIGO 2022 recommendations regarding ACE inhibitors and ARBs for a patient with diabetes, hypertension, and albuminuria, it is recommended that you should have your ACE inhibitors and ARBs. If you have a patient with diabetes, albuminuria, but the blood pressure is normal, you may still consider your ACE inhibitor just because of the proteinuria and titrate these patients to the maximum tolerated dose. And there is strong evidence of, doing your ACE inhibitors if the proteinuria is more than 300 milligrams per gram or the eGFR is less than 60. But in those with diabetes and hypertension and the ACR between 330 to 229, that's a level B evidence. Just go through the evidence that have driven the use of SGLT2s in addition to your RAF inhibition. Back in 2009, we had a presentation of Credence trial, which used canagliflozin in patients with type 2 diabetes, all of who also had ACR more than 300 milligrams per gram. Split into two groups, one group to have canagliflozin 100 and the other group to have placebo. And at the end of the follow-up, there was a 30% relative risk reduction with a numbers needed to treat of 21. That was the first trial that showed, renally dedicated trial that showed improvement in the primary outcome, which was much, very long awaited. We hadn't had any news like this since the ACE inhibitors and the ARBs about 20 years earlier. Subsequently, we had the DAPA-CKD trial, again, similar sort of trial design, except that this population had patients with and without diabetes. But this time we used dapagliflozin 10 milligrams versus placebo. And again, at the end of the follow-up period, the composite, the primary outcome was reduced by 39% relative risk reduction, and the composite kidney outcome was reduced by 44%. And this actually just confirms, the initial data from the Credence trial, but in a much more broader population. And recently, we had an EMPA kidney trial as well. Again, looking at another drug in the group, empagliflozin, similar to studies done, but a lot broader. The population is a lot broader this time. Patients with and without diabetes, and this time also had a significant proportion of patients without albuminuria. And again, we've seen consistent results, 28% relative risk reduction at the end of the follow-up period. So you put all of it together, you put all the data together, the EMPA kidney and DAPA kidney results, and you are seeing consistent, reduction in kidney outcomes, which is now driving the guideline changes that we have seen in the KDIGO. So we did mention, the lifestyle changes and pharmacotherapy. Don't forget the cardiovascular risk reduction, blood pressure control, focus on A1C optimization, and optimizing your ACE inhibitors or ARBs and your SGLT2 inhibitors. In addition to that, there is now a fifth pillar, which is the non-steroidal mineralocorticoid antagonist, pinorenone, the first one in the class, which has been shown to also lead to significant kidney outcomes. And in the next slide, I would just go through that. So for the busy jobbing GP, the mode of action for pinorenone is just basically inhibiting inflammation and fibrosis in the kidneys and in the heart. And that leads to some positive outcomes, as you can see in the next trial that I'm going to present. Trials regarding pinorenone were two, Fidelio DKD and Figaro DKD. The Fidelio DKD was a renal dedicated study which looked at chronic kidney disease progression as a primary outcome. And the Figaro was a cardiovascular outcome trial of that drug. And that looked at cardiovascular mortality and morbidity reduction as a primary outcome. And in both of these trials, statistically significant reductions were noted, 18% in the Fidelio DKD and 13% in the Figaro DKD. And both of these trials showed significant reductions in other secondary outcomes, CV mortality and morbidity, and CKD progression in the Figaro. The trials were pulled together in pre-specified analysis called the Fidelity trial. And in this study, this analysis, there was a 14% reduction in the time to CV death, non-fatal MI, non-fatal stroke, or hospitality for heart failure. And this was statistically significant. In addition, there was a 23% reduction in the time to kidney failure, sustained eGFR decline of more than 57%, or renal death. So as you can see, the evidence is now very rich when it comes to the pharmacological management of people with chronic kidney disease, with or without diabetes. And as I've shown earlier in the KDIGO flowchart, there are a lot of options after your lifestyle intervention, ranging from RAS inhibition to SGLT2 inhibitors, adequate glycemic control, lipid reduction, lipid lowering. And if you do so have increased proteinuria after that, you can add your MRA. And if you still need optimization of glycemic control, a GLP-1 receptor agonist is an option. If you need blood pressure control, calcium channel blocker, in addition to your RAS inhibitors, is also adequate. Thank you very much. And I'll hand back to Baruch.
Yes, Sam, thank you very much for this interesting overview about the treatment options in CKD. And you gave us a very clear message of treating our patients in a holistic way. Not only the kidneys, also other risk factors, and it's very important. But still, I would like to ask you why we have still this gap of treating our patients in the best way. What do you think, and what solutions you suggest for overcome this gap?
Yeah, so I think, Baruch, thanks. It's a great question. The knowledge is increasing in this area, but education has been one of the things that has been lacking. And it wasn't necessary because for 30 years, we have had RAS inhibitors, which we have been using to control blood pressure. And indeed, we've also known for years that even in normal hypertensives, if there is proteinuria, RAS inhibitors are still useful. So we have been doing that already. And there really was no point to want to do anything else until recently. We've now got the SGLT2 inhibitors and the MRAs also coming. So education about the new additions is important. Additionally, the other barrier for treating is just the workload. Like we said earlier, our GPs have a lot of other chronic conditions that they have to manage at the same time. And learning about all of these and addressing them in the same clinical setting can be a bit daunting. Thankfully, a lot of these conditions tend to go together. There is something I call the concordant long-term conditions. Conditions like blood pressure, chronic kidney disease, heart disease, and diabetes have similar pathophysiological pathways, and for that reason also respond to similar interventions, be it lifestyle interventions or pharmacological therapy. And so having the patient in one clinic, you can actually address a lot of these things at the same time if you know the right therapeutic options to consider.
Thank you, Sam. Louise, what do you think?
Yes, thanks, Sam, for that excellent presentation. I think, I think it's clear to me to make things happen, we have to make them extremely simple. So I think your messaging, Sam, was excellent. And I think if we think of pillars, we did describe sort of diabetic kidney disease. And I think we're starting to think of pillars with that. We're thinking of pillars now in heart failure. And we're, as you said, we're seeing some consistencies. So regardless of the type of CKD, we can still focus on that lifestyle, the reduced salt diet, as we heard of, the movement, obesity, or addressing obesity if it's a concern as broad statements. Again, blood pressure management is a consolidated statement across all vascular disease. Certainly, if there's proteinuria or diabetes, we look at ACE-ARBs as first line. So I think that's a consistent message. SGLT2 inhibitors are indicated for both non-diabetes and diabetes, as Sam so nicely showed us. I think important areas we don't use it in are type 1 diabetes, in people who are on significant immunosuppression, people that have perhaps these recurrent genital fungal infections, some concerns that if someone's got instrumentation in with their bladder, and in people who've had DKA. So relatively short list of who not to use it in. So again, starting to be broad pillars that encompass both CKD, vascular disease, and heart failure. And I think keeping those pillars kind of front and center, adding in the SGLT2, certainly in diabetes, we'll consider as second line finerenone, some early evidence about the GLP-1 agonists and outcomes. But we start to get a toolkit and we get familiar with those tools. We likely just need to pick one SGLT2 inhibitor, one ACE inhibitor that we are comfortable with. And then we get a small list of drugs or medications that we're familiar with. And then I think that's the ticket of it. And if you're uncertain, to ask, because these drugs that Sam presented, SGLT2 inhibitors, have been really revolutionary in their outcomes with vascular disease, cardiovascular, heart failure, and kidney disease. So important that it was something new that the primary care may have to do familiarize, have a conversation, listen to a podcast, whatever is the opportunity that best suits you to learn about these new opportunities to reduce our patients' risk and improve their quality of life. Thanks.
Thank you very much, Louise. So if I understand well your important messages, both of you, Sam and you, we have today new medications that are cardio and renal protective, and we should use them in the correct way and early as possible in order to reduce complications in the future.
Yes.
Agree.
Correct.
Yeah. Okay. Thank you very much. So this is David 10 years later. He is coming again to our clinic. He's already 67 years old, already with 25 years of diabetes, still on dyslipidemia, hypertension, background diabetic retinopathy, and already, unfortunately, 3-vessel disease, a cabbage operation that he passed 5 years ago. And according to the echocardiography, he has also heart failure with reduced ejection fraction. His blood pressure now is 120/80. His body mass index is 29. His A1C is 7.6. His estimated GFR is now 44. I remind you that he was 90 at the beginning. Now he is 44. His urinary albumin creatinine ratio is 500 milligrams per gram. His total cholesterol is 133. His LDL cholesterol 98, HDL cholesterol 40, triglyceride 250. His ECG is normal, but again, in his echo, cardiography, you can see left ventricular hypertrophy and ejection fraction of 40%. His current treatment, sitagliptin and metformin extended release once a day, dapagliflozin 10 milligrams once a day, glyramperide 4 milligrams, ramipril 5 milligrams, furosemide 80 milligrams once a day, hydrochlorothiazide 12.5 milligrams once a day, atorvastatin 40 milligrams once a day, and bisoprolol 5 milligrams once a day. So putting him under the classification of KDIGO according to EGFR and UACR, David has now actually the stage 3B, putting into the table on the squares. Then we can see again EGFR 44 and UASR 500 milligrams per gram. The point is now that he is already on the red zone. Red zone means very high risk, over 300 milligrams per gram albuminuria and decrease of EGFR. So what we are supposed to do now? This is the time maybe to refer him to a nephrologist consultation. And actually, this is the time to hear our colleague, Louise. Louise, the stage is yours.
Thank you, Baruch. So again, it's as the family doctor who we really understand does so much work for so many different conditions. I think this is an important one. And these are sort of standard. I think everyone agrees with these terms to refer to the nephrologist, the specialist, to get some consultation as to the best practice for moving forward, and also to engage with the patient. So again, as you can see on the left, the clear indications an EGFR less than 30, consistent proteinuria greater than 300 milligrams per gram, as we've seen here, or an EGFR less than 45 and proteinuria greater than 30. So again, when we look at that, if we were to mark those out, I'm not sure if you can see my pointer, but all of those take us over into that range of sort of the orangey red color. And if you can read it, it says treat and refer because of their risk being higher. And again, the last concept I'd like to introduce, if it's not familiar with you, if there is a 5 risk of kidney failure in the next 5 years, that's defined as needing dialysis, transplant, or dying of kidney disease. And for that, we look at a risk equation, the kidney failure risk equation. And if that's greater than or equal to 5%, it does deserve referral. Now, again, these equations can be difficult to remember, and I actually don't think we can do this one in our head as it has some algorithmic terms to it. But again, this risk equation calculates both 2 and 5 year risk if the EGFR is less than 60, and it may help you to decide about referral. And recommendations or referral are if it's a greater than 5% risk in the next 5 years. And again, it can be used, it's been validated in people across the globe with EGFRs sort of in the stages 3 to 5, so down to close to 15. And it includes not only the EGFR, but also the ACR, as we talked about being important, as well as the age and the sex. Again, other indications for referral could be unexplained progressive decline in EGFR. And as people age, we do see an EGFR decline. And, as we get older, and certainly if there's any other issues going on, can be about 1 mil per year. And certainly in conditions such as hypertension, certainly diabetes, if they have proteinuria, if we take a population, it's about 3 mils per year. So if you're seeing a patient that you're quite comfortable managing with diabetes that has some significant kidney disease and perhaps proteinuria, but you see that decline is quite quick, so more than 5 mils, again, all of these are hard to calculate exactly, but you're going, gosh, that seems like a more rapid decline. That would be an indication to refer. And again, unexplained significant albuminuria, proteinuria, or hematuria. You might be comfortable managing with some proteinuria in a diabetic, or perhaps a little bit of proteinuria in a hypertensive. But if you're a hypertensive non-diabetic patient is spilling a significant amount of proteinuria, that's atypical, probably atypical in your practice. And, sending them along for referral would certainly be appropriate. I think persistent hyperkalemia, high potassium, resistant hypertension, defined as uncontrolled hypertension on 3 antihypertensives, including a diuretic, recurring kidney stones, which is quite a prevalent problem, hereditary kidney disease, such as adult dominant polycystic kidney disease, are all indications for referral. Other complicated things can be anemia that you think might be related to the kidneys, mineral bone disorders, hyperparathyroidism, whether it's primary, secondary, metabolic acidosis, and other electrolyte abnormalities, including low and high sodium. I think anytime you're suspected of this glomerulonephritis or renal vasculitis, if you see blood in the urine that's unexplained, certainly if somebody's having systemic features, they're unwell, you've had recurrent in lung infections, it seems to persist, and you're just thinking something odd is going on, please do a creatinine and an ACR and then refer along if needed. And again, I always say, I refer to others when I'm uncertain of my next step. So in neurology, that might be an early referral. In cardiology, maybe less so. So I think we have to use that barometer besides guidelines. And I can, consider you want to use a medication, perhaps you're uncertain about SGLT2 inhibitors, or perhaps you want some new information about finerenone, that, you want to see how the expert uses it. That seems quite reasonable. And managing patients, but you want to review if there's anything new. So, you're quite comfortable managing that stage 3 CKD in a diabetic, but you will hear there's many new things, and you'd like to see the approach of the specialist, and occasionally referring that, what you might say is a standard patient, just to see what those updates are, I think is completely acceptable. And again, I think important, how do we communicate? Everything is about communication. So I've just listed some things there for it. Very important. Sometimes we need patients' emails if we're going to be setting up email communication or doing things via WebEx or something. I think very clear, what's your question? It's not always a diagnostic question. Sometimes you want us to discuss certain aspects of care, letting us know a little bit about their history. If there is an electronic record that can be shared, certainly medications are very important, as well as your contact. How do you want us to contact you? And many of our colleagues, we contact each other now a bit more electronically than waiting to get through on a telephone. And again, what should you expect from a consultation from a specialist, and in this case, a nephrologist? Well, generally to confirm or reassess that diagnosis. Like, it may look like diabetes, but maybe there's something else going on. So you're asking them, they should be considering investigating further if needed, to do the additional tests and imaging. Again, optimize those risk factors for management to reduce further progression and reduce risk. And again, when we talk about risk, it isn't always just kidney risk. We're really talking vascular risk because we're one body. So much, I often say, if it's good for the heart, it's good for the kidneys. Optimizing management of blood pressure, diabetes, lifestyle, obesity now, and known to be an independent cause of CKD. Review of medication safety. As certainly additional management strategies for electrolytes, metabolic bone disease, as I've discussed, anemia, and of course, fluid management. Importantly, I say is provide education on chronic kidney disease and progression and what to watch for and what patients can do. They often say, what can I do to help this? And I think sometimes going to a specialist really brings home that this is an important issue and we have to all work together. Depending on the stage, we have to look forward, plan for renal replacement therapy, get support for decision-making. And again, at this stage, many of us are reviewing overall goals of care. This is now getting where we're getting into that pre-planning for looking at renal replacement options. We need to review goals of care, choices, including conservative management, and really working with families. And we have at this stage allied health teams that are often joining, including social works. Thank you very much. And I think I'll pass it back now to our chair, Dr. Baruch, to facilitate further discussion on this. Thanks you.
Thank you very much, Louise, for this comprehensive overview about indication for referrals. But still, I would like to ask you, there are still lack of referrals and barriers to refer to nephrologists. So partly you have mentioned solutions to use in order to increase the referrals if they are needed. But what do you think we should do as solutions for those barriers for the future time, for the GPs, to help them to create a better atmosphere of referrals to their specialists, the local specialists?
Mm-hmm. No, I think it's a very good question. I think if the GPs feel that they could use some support with that, I think, start to send referrals, if possible, to nephrologists. I'm hoping I catch your question right, Baruch. And then, often you have work better with some people than others, or you get better responses from one than the other. And that, I think, helps us to set up that pattern. I also believe that any kind of communication besides a piece of paper, which we still often fax back and forth, seems rather archaic in this age. So any opportunity that there is to actually speak to these people, to set up the community or the team, would be very helpful. So if there are any opportunities, to do CME or any kinds of, to meet and greet with these people, I think that's often when you're at them, is to introduce yourself and set up that relationship so that it becomes more comfortable to give them a quick call or give them a quick email to move that forward. Again, I think it's about relationships and building teams in medicine. And I think communication has a great need to be enhanced besides, faxing things and having this communication pathway that never involves people.
And maybe it has also a learning effect between the specialist and the GP. Absolutely, about the same case. Mehmet, what do you think about barriers of referrals and solutions?
I think the lack of the training and education and a lack of the spare time for the GP is a real barrier, I think. And if we are aware about, some certain level indicators, let's say, like those tests, and if we are really on time, I think we can prevent most of the advanced cases, I think. So this is the training and education and collaboration is the most actually biggest problem, let's say. And in some certain areas, I know that it's not easy for the gatekeeping role of GPs to refer the patient easily to the nephrologist, unlike some other developed countries, let's say. This is also a barrier which the system shall allow free of services for the patient to get it from the specialist, to go to the specialist and to get it from the specialist especially. And sometimes some ordering tests are not, if you actually, we are following usually those hypertension and lipids and everything in many countries, but in some countries is even asking tests is not easy depending on the system where you are. So I can't generalize as a problem, but the main problem is easy, small frame and very, very easy to take messages by nephrologists to the GPs, not making it a huge training, but small messages. They are very important, I think.
Thank you. Thank you both.